Hello and welcome everybody. Do come in and get comfortable. We'd love to know where you're joining us from. We've got a large amount of people signed up today and we really like to see where people are joining from around the world. So if you just pop that in the chat, we can see who's here.
Exciting.
Yeah, oh, we love this, don't we?
Absolutely.
Bart is
Excellent.
in Lyon, France this week. He is at the European Pain Federation conference. So
Yes.
he's in a slightly sunnier location and outside.
Oh yeah, that's this was the quiet and good connection
Yeah.
area, I guess. So yeah, it's lovely to be here at the European Pain Conference, which is the last one was in Budapest, and this one here in Lyon. It's like I think about 2,500 attendees,
Yeah.
delegates, and it's good to see. We basically the whole pub science session library is walking around here. So for us, this is a great opportunity to share and connect with everyone who've been working virtually with.
Yeah.
And I just said to Tim, or Tim said to me, "Well, it's fun. We know these people by face, but you never know what's under, right? So we just have to sort of to figure out how tall or how they look like. So sometimes you misinterpret that totally. So we had a bit of a good laugh on that. So yeah, this is perfect place to be today, tomorrow. Yeah.
Amazing. And Bart's also recruiting some more speakers for some more science sessions and clinical confidence coaching. So it's
Yeah,
really
there's
exciting to
anyone,
see.
yeah, check the website. You can see the speaker lineup here. And as if there anyone you feel like, oh, that would be great to have that person on for a science session or clinical confidence series, just let us know. We have an opportunity to connect them directly. So,
Yeah, they're
cool.
running around, aren't you?
Yes, and they're wild.
Yeah, I can imagine.
Yeah,
Welcome,
great.
Sarah from Bristol and Alcia from Sydney, Australia. Sorry if I pronounced that wrong. I am terrible at pronunciation. Justin from London. Welcome, welcome. Pauline from Bournemouth in Dorset. Welcome. Do let us know where you're joining us from, guys, because it's really nice for us to see. So we're not going to hang about. We always run out of time. There's so much to share. We're just going to get going straight away. So we have a little introduction that we like to do, so we make sure we cover everything and don't forget anything. So I'm just going to go straight into that. So good afternoon, good morning, good evening, wherever you are in the world, and a very warm welcome to this introduction to treating functional neurological disorders. My name is Joanna Taylor and I am co-founder of Le Pub Scientifique. Le Pub Scientifique is a vibrant online community where passionate clinicians gather to master treating people with all types of pain. We bring world-leading expertise straight to you in a way that is completely different to your usual CPD. Smart, supportive, and a lot of fun. I'm joined today by pain specialist physiotherapist and my very good friend, Bart van Buchem. Bart is also co-founder of Le Pub Scientifique and has a special interest in treating functional neurological disorder. Hi, Bart.
Hello.
We are bringing you this session today, excuse me, by way of an introduction to our brand new functional neurological disorder masterclass, which is available with Le Pub membership. For those of you who have either completed it or are currently working through it, these webinars are designed to support your progress. And if you haven't signed up for the masterclass, today's session will give you a really good taste of the comprehensive approach we are taking to translating the complex neurological concepts into effective clinical strategies. I will drop the link in a second in the chat to the masterclass, and you can check that out whenever you like. So I'll run through what to expect here this morning. Bart and I are going to be talking for about 20 minutes. If you have any questions, please put them in the Q&A or the chat and we'll get to as many of them as possible. We often run out of time, so I would urge you to get your question in early if you want it answered live. So today we're talking about treatment strategies for functional neurological disorder. So Bart, would you just explain what you're going to cover in the next 20 minutes, please?
Yes, so it's quite ambitious, I can tell. So we hit some of the brief introduction to FND and what have changed over the last years, and I would say the last decade more specifically. We're going to touch on some assessment and diagnostic criteria, basically how this diagnosis is made by a neurologist, because that's important to stress that it's a neurological disorder nowadays. And yeah, I'm going to give you some insights in treatment fundamentals, like concepts, some understanding of how this symptom-led treatment approach is like. And yeah, I think it's very excited. So we should be able to start working on your clinical confidence while you're treating people with FND. And even if you haven't only started seeing people or never seen people with, they came across without knowing. But I'm pretty confident that even today's session will be quite helpful to get to sort of shift your understanding a bit and getting more comfortable with this condition.
Amazing. Right, let's get into it. I'm really excited. The last one we did was absolutely mind-blowing. So, could you give us a quick overview of what FND is and why it matters to physios and other healthcare providers in their daily practice, please?
Yeah, so as FND is nowadays a neurological disorder, as it used to be a psychiatric disorder. It's still in the DSM-5, but the most important thing, as it used to having what is used to be conversion disorder, known as people with motor impairments like loss of sensation or loss of strength or gait disorders, dissociation, were basically diagnosed when there was a stressor or there's a trauma-induced event that made this happen. So basically, the body disconnects from the brain. That was the old narrative. Nowadays, it's not necessarily to have this psychological factor. It's not. It's a diagnosis made on inclusion, and because these symptoms are very neurological, as loss of strength or loss of sensation, or the other way around, like hypersensitivity, and the gait disorders are very alike. For example, Parkinson's type of symptoms, but someone has to differentiate. So this is where the shift has been made, where a neurologist is probably in the lead now to set the diagnosis. And in some cases, a psychiatrist or psychologist is very helpful and very necessarily part of the treatment, because there is a high prevalence of trauma in this group, but not all of the patients have this type of background or this induced trauma-induced symptoms. And what we also found that it's not psychotherapy that necessarily do the work, it's also a neuro rehab type of treatment that seems to be beneficial for many patients. So that's a massive shift, right? That's massive. Whether you would, in the early days, it will be ruling out or not even thinking about neuro rehab for patients with a gait disorder. Nowadays, actually, it's happening, and the research is building at the moment. So the recent research has shown benefits for people even with these psychiatric comorbidities, also benefit from motor or neuro rehab style treatment, which makes sense. And I think many of us sort of had experiences where people with these complaints do really well on like a physical treatment. I wouldn't say physical because maybe that's a bit of a odd word choice. Although like this neuro rehab style rehab thinking, it can be very helpful. So yeah, and I'm excited about this because as a therapist, you can imagine that this is a new area.
Yeah, yeah. There's been a lot of change, hasn't there, in the last 10 years?
It is, yeah.
Yeah, yeah. Thanks, Bart. So just moving on, in terms of assessment and diagnosis, what are the clinical signs of FND and how are these positive signs assessed?
So just in a nutshell, for example, there are specifics in FND that you won't see in Parkinson's disease, for example. So and I want to stress that a neurologist is critical in this part of the treatment, or even in setting the diagnosis, because it doesn't go down well if there's uncertainty around. As this is a diagnosis by inclusion, you have to find, or you will observe, symptoms that are typically seen in people with FND. For example, dragging food with an exorotation of the foot, and people dragging the foot behind them, and that's the way how the gait has been observed. So you probably, that's something you only see in FND. So a neurologist will ask the person to walk backwards, for example. And then they can see a massive improvement, because people can do stuff that I couldn't do in the other direction. It's also this inconsistency in some degree, or tremors, where people having a tremor, but once they got distracted or having intentional movement as a comparator, then this is called entrainment. So therefore you can directly get this tremor changed in its frequency, or sometimes it even disappears totally. So that's I would say in a nutshell, like from an inclusion point of view, whereas other conditions like fibromyalgia, for example, like a typical pain condition, is been by exclusion. So because it's not this, it must be that, and that's by no means, that's not ideal, but it's the best available at the moment. But for FND, there is pretty tight guidelines nowadays, and for every type of neurological deficit, there's an option for a neurologist to make to include whether it's FND or not. And so this is why in the product, so in the course, in the masterclass, we have this neurologist talking about all the nitty-gritty of this diagnosis and how to set it. Yeah.
I think the thing that strikes me most is the speed of the change in understanding this condition within the last 10 years. There seems to have been a huge shift in how it's regarded.
Yeah. And you have to be aware of the fact that it's been stigmatized for a long time, as it happened. And there's a long history of chronic pain, people not being believed, making things up. And you can think that's not going to be helpful. So having this by inclusion is a big shift for patients. Even changing the name has been important, because so many people really dislike the idea of conversion. It's a very Freudian, from Sigmund Freud came up with that terminology, basically converting something into something else, right? And even today, there is still a massive stigma going on, but for a patient's point of view, this is absolutely helpful, at least helpful from their perspective to there's a different name and there's a different approach, and therefore the stigma is reduced massively. And we have spoken to patients that it's massively important for them to have this diagnosis.
Thanks, Bart. I mean, this is going to bring us on now to what we're focusing on in this session, which is the treatment of FND. So that brings me on really nicely to the next question, which is, how do you explain the diagnosis to patients in a way that helps you to build trust?
Yeah, that's a great question, as it is probably depending on the person, how you're going to bring it. But you could phrase it as something it's an issue in the system, in the premotor system, if you like. For some people, it'll be like a system, like an alarm that's malfunctioning. It's creating different vibes and things that weren't there, but it's sort of labeled as a mismatch. I think from a scientific view, that's probably not quite correct. But just for layman terms, instead of saying this is a psychiatric thing, or it's in the head, it's basically how things are being adapted in your system basically, and the output of movement is going to get disturbed. So there is a mismatch. For some people, it's like other ways of explaining. It's like a piano that seems to be look all right, but once you start playing the piano, in some way inside the piano has changed something there, and therefore the tones are not, they're off pace or they're mixed up. And then you can see you think you're doing this and it doesn't work. And the more you do it, the more obvious it gets, and the harder it gets to change or shift that. And to be honest, we all have experienced kind of FND type of symptoms. So everyone's had a bit of a tremor at some point, or a little bit of like a myoclonus, but that's only that little deficit, maybe induced by fatigue, for example, is only there for a moment. So people with FND may be stuck. So the question is, in this case, why doesn't it reorganize itself? What's the problem in reorganizing? Because having these symptoms is not really the problem, but it's why they are not disappearing. It's why doesn't it recover itself?
Lovely, thank you. So from your clinical experience, what are the key differences in your approach when treating patients with FND compared to other neurological conditions? And how do clinicians need to adapt their mindset?
Yeah, I think it's key, because I think people could do very well, patients could do very well, like if you treat a person with a tremor, like a Parkinson's tremor, you could do exactly the same. But in a large percentage of the group, you will see if you do not drive attention away from the tremor, or you're not adequately labeling that as an issue, because attention is a big driver, it's a strong driver for FND, as it is not as much as for Parkinson's. So you will see similarities, but distraction is something that probably needs to be trained. You need to give people tools to operationalize the way how they distract themselves or moving their attention away, because they seem to have an inability to move attention away. It's a bit like thinking about the pink elephant. You cannot not thinking about it, all right? It's terrible, but if you do not have the skill set to change that, that could be instrumental in FND, instrumental. So you could do all the cool exercises you can think of, but if the attention part and the focus part is not being changed, or the person doesn't understand what's going on, that could be delaying your results, or at least it could be problematic at some point because people don't get control without the help. So it's all about putting the patient in like self-control, and on top of that, giving them the necessary things that may or maybe inducing it. So if there is a stress-related factor that induces this, there will be a reason for like a focus on that as well.
Brilliant. Could you give us a quick example of an effective movement retraining technique that you may use?
Yeah, I think tremor is very obvious because you can observe the change. So entrainment will be basically when someone's having a tremor, like my hand does it. When I'm watching it, it's increasing. When I drive my attention to the other hand or make movements, it's called entrainment. You can see it disappears. So the tremor, the frequency will be directly shift to maybe even disappear. To operationalize that in a real life example, that will be giving people an exercise that actually help them to make them aware that it actually happens. So I tell the patient that, try it now. How does it feel? What's the difference between when you do this entrainment type of exercise compared to watching it and feeling and trying to stop it by basically holding yourself? You can see that's interesting. People will be they will say something like, oh, it's so much easier. It makes me calm. It makes me more comfortable. So otherwise, then you can give people an exercise that they could use the entrainment basically when they wearing their hands in the pocket whilst they trying to get a cup and trying to drink. So it's from bench basically to bedside. You could say, well, probably from the clinic to real life, then you need to find a way how they can operationalize that and can use it in a way that it's, well, at least it reducing the issues or the symptoms that evolving. Typically, and if that works in a clinic, you can see massive changes very fast. So people start using it because they genuinely enjoying doing it because it's so much, there's so much, there's so much effect basically. And it's very, I would say, not too demanding. But some people just need to learn how they're going to distract themselves or being calm. So it's not just moving the attention away. It's not just entrainment, but it's also see what it is, how it's affected and how you can maintain this condition. And that's where we support people to sort of follow or be comfortable or finding ways to induce that typical condition, that feeling that doesn't goes along with the tremor. And whether it's a spasm, a tremor, or something like an involunteered movement or a gait disorder, the principle is very similar. And I think we have in the course, the masterclass, we have many examples of different types of FND that seems to respond very well to this type of treatment because they're typically motor deficits, right? So apart from dissociative disorders, which is like people like they fainting in a way, or this functional dissociative disorders, those won't respond to this type of treatment because there's no motor issue in its own right. So you will see there is a big variety of different patients and types of symptoms.
Oh, there's so much. I can hear that there's just so much that you could keep talking about here.
Go forever.
So Dini, I think that probably answers your question, which was, could you give a distraction example for gait disorder symptoms?
Yeah, so just briefly on the gait, let's say the dragging foot, or it's this when it's like a myoclonus type, or people are losing their strength at some point during the gait. Or having funny movements with the leg, how they move forward. It's not necessarily about distracting. I think it's putting your attention to the thing that actually works. So even moving attention to the intact leg, so the non-affected part, can also be very powerful. Using that by even providing very complex movements. You wouldn't do that with a Parkinson's disease diagnosed person, like aiming too high, but some people with FND do very well when you play games with them, do unexpected movements or not. You don't have to scare them off, but you can challenge them in a way that actually can feel the difference. And that's probably the most important part, in my view, is that once you have this distraction, it works, you have to start shaping it. You have to start working on that. And people have to be part of that journey, understanding that actually is a good thing. Don't say like, oh, why are you you can walk backwards, so why are you worried forward? So just do it. That's probably not going to work out really well. So it's a quite subtle way of getting this positive motor experience and then shaping it onwards. And that's very much based on behavior therapeutic approach.
Thank you. I just want to say, Felicity, I've got your question and I'm going to come back to that. I'm just going to choose Alyssa Brooks's question here because it fits. Any tips for distraction imbalance disorder symptoms?
So one of those things that you probably have to get out of the box, thinking out of the box in terms of like how we train from the neuro rehab typical way. Well, this is easy and this is hard. You have to let that go, because people with FND could do very well if you are challenging the task, even in a way that you thought, well, that cannot be. So sometimes you have to get across your own biases and thinking, well, did we really try everything? And like an amazing example that I had at some point with someone with this incredible balance, like Goria type of, so they're like all these involuntary movements and dizziness that I experienced, that we start running, like real running. I could tell you, like sprinting, like moving like you never run. And that worked out really well. And then instead of, and it feels from a neuro rehab point of view, that sounds super stupid. And it doesn't make sense in many ways, but it does for FND. So from running back to walking, that's basically the treatment approach is. So it's the opposite, how you create this trajectory. Well, again, it's probably too hard to get to the details, but I think from even the way how you use your vision to calibrate, there are many ways of focus that could be more helpful, but in many times we see that we have to sort of we have to think out of the box as therapists, being more creative and see how that turns out.
Thank you, Bart. A question here from Ethan. Any thoughts on rhythmic auditory therapy for FND patients?
Well, absolutely. Well, there is absolutely, some people do great on rhythm, others do rubbish. If it increases the symptoms, it's probably not a good idea. It's try and error in that perspective. But if you maintain, or you think, well, this is if you go on drum and bass, for example, and even if you hate it or not, if you go on drum and bass and do very well, it's probably drum and bass is the way to go. But if it's like on a waltz, like people like dancing in a way, and it don't go that direction, because it's shown that if people will drive their attention, they started to have an experience with the music and then probably conditioning the response in dancing in that particular way. So there's a lot of reason for being careful with thinking what is right or wrong. It's about thinking what works. And I love to work with rhythm, and many people love dancing. And that's probably not the first thing you do if you have been diagnosed with FND, but I can tell you I've seen many people dancing in my clinic and they do great.
That's a great question. Thank you for bringing that up. That was a really interesting aspect. So what we're going to do now is we're just going to wrap up on the questions. Well, we're going to finish the questions that are in the chat, and then we'll give a quick summary before we head off. And I'm going to ask Bart to give us some like take home quick techniques. So Felicity, I'm coming back to your question now, and your question was, what are the key differences between functional neurological symptoms versus FND? Some patients are diagnosed with functional neurological symptoms due to chronic pain, but not FND.
That's a really good question. And depending you're asking, I see patients with chronic pain like CRPS and do have this functional dystonia, for example. That's a good example. I guess that is quite common. There is a big debate going on. I can refer to some discussions that are happening in the literature at the moment. But so it depends. If you're asking the neurologist, they probably would go for this is FND and the pain is comorbid. If you see a pain specialist, they say, well, this is definitely a pain issue. This is driven by and their comorbid FND symptoms. So I think just to prevent any semantic discussions here, as a therapist, when you work with people in pain or people with FND, it doesn't really matter what's on top of the list. They can make up their own list, right? So they have their issues that come across their life, and it's disabling. And whether it's a tremor or it's a painful tremor, what is then FND and what is the pain thing? I think it might be not relevant to sort of trying to distinguish that, because it's not helpful for the treatment. There are reasons, but that's also more in detail. So what is it the first thing you treat? Well, my experience generally from pain compared to FND is that you can observe changes in FND easier than chronic pain. And as pain is an experience, FND could be experienced as well, but it also has very obvious motor output changes that you can see, and if they're absent, people do generally do better. So if there's a possibility to focus on FND and having success, and I think that's you're creating an amazing alliance with your patient to have some success in one part of their disability, or that's driving their disability. So yeah, my view on that. So if you want to have success, focus on FND, and pain will be the comorbid. It will be the thing that is super relevant, but probably not that's driving your therapy at that stage only. Yeah.
Got you. Brilliant. Thank you. A question here from Irali. What do you believe causes the onset of FND?
We don't know. Could be anything. There are studies that suggest that people are already vulnerable, so it's a matter of the last bit that basically elicited, but then blaming the last thing, that would not be necessarily the greatest thing to do. So that nobody knows exactly how and why it's happening in some people and other people don't. But I think it's most importantly, it can be anything that induce it as a trigger. But the cause of FND is unknown as far as we know. And in a part of the population, trauma is very relevant because, and we know now in this conference as well, we talked about trauma as a large it makes it, especially on early childhood trauma, for example, makes children even more probing for prior for chronic pain. So it's a correlation. It's not a causal relationship because there's still kids with childhood abuse and stuff and don't get chronic pain, but there is a fragility, or people might be more prone to it. And I think that will be very similar with FND.
Thank you. Last question. How do you manage severe collapsing weakness, collapse to ground, unable to lift arms, head, hold up torso, bed bound severity?
All right, that's a very specific case, but I think when it's severe, you have to be very calm as a therapist. Most people with FND don't hurt themselves when they collapse. Not saying all of them do, so you have to be warned, but if they don't hurt themselves, let them manage that. Be there with them, help them to manage what's happening, because you cannot go on rewind. You have to go through the process, keep talking, because it's very likely they can actually hear you and they have a conscious experience of what's going on, but they are not able to respond in a motor way. So whether it's talking or lifting, and just be there with them. And that's probably the best thing you could do at that stage when it's happening. It's a bit tricky when people do hurt themselves, which I found that's only seen in a small percentage, as we know. It's like about 1-2% has this very terrible condition that doesn't seem to go over, and it's disabling in a very terrible way.
Thank you, Bart. Very last quick question. Is it linked to POTS? From Claire.
So POTS, for people who don't, so it's related to long COVID, for example. People do exercise or even cognitive emotion tasks and they get totally drowned. They get like so fatigued that's exhausting. I do see people who have, and I think that relates to an earlier question, is FND symptoms are seen in people with long COVID as well. Yes. Is long COVID FND? I'm not sure. And I'm not sure if it's helpful to go that direction, but I can see there's a correlation. There might be people with POTS who do POTS or POTS who probably have also these neurological symptoms that you might see, and they might benefit from this type of treatment to manage part of their disability.
Okay, thank you, Bart. So you have given us so many different ideas here for treating FND. And obviously you could go on for ages, but that is where the masterclass comes in. So just before we tell people about the masterclass, can you just give us your most valuable practical techniques or exercises that clinicians could take away from this session today and implement with their patients?
Yeah, if you have a feeling, this gut feeling that FND might be an appropriate condition or the diagnosis, before going into referrals and stuff, if they're in the clinic anyway, you go try stuff. Go see if you can drive attention away from the affected limb and trying to give them some positive motor experience, trying to explain a bit how it might work, even without not really knowing whether it is this condition or this is the right diagnosis. But you can try little things to make it probably more likely that it will be FND. And I urge you, just and be creative. Try things. Don't limit yourself to we're not dancing in the clinic. Well, we will do dancing in the clinic. Use music, use play, use things you've never done, especially with this group. It's very helpful. So there's like it's a bit of maybe like a not a specific exercise, but I think it's the mindset that's going to be very helpful.
Thank you. Thank you so much. What amazing knowledge you have, Bart. Oh my goodness. So thank you, Bart. And today Bart has given you a high level introduction to treating FND. But if you want to really master this condition, the FND Masterclass that we've been talking about throughout this is available as part of a LePub membership, which is £150 for access to the masterclass and our whole back catalogue of clinical confidence coaching series and science sessions with the world's leading researchers and pain experts. So Bart's just going to tell you a little bit more about what you could expect if you did decide that you wanted to sign up and take part in the masterclass, which is an online, on-demand learning experience. But who's in the masterclass and what can people expect to get out of it?
Yeah, we found some really cool people to
Really
collaborate with us. It's Professor John Stone. He's a consultant neurologist. He's probably the founder of FND in a way of the shift. He's been instrumental. Dr. Jeanette Glaus, she's a neurologist in training, but she has a PhD and did her whole thesis on FND and its prognosis. And she's talking about all these inclusion criteria of these different types and different variations of FND. And we've got Sonja Rutten, she's a psychiatrist, and she has more than 25 years of experience with working with FND. And she's also co-author of the guidelines that are being rewritten and being republished at the moment, where I was part as well as part of the treatment part. We have revisited that. And Dr. Glenn Nielsen, he's a senior lecturer in London, as he has he was the one who set the first randomized clinical trial on this approach as well. So we had conversations with him in depth of what this treatment does, also from the perspective from the therapist, but also perspectives from the patients. And they've seen a couple hundred patients, so that's quite interesting data. And the experience has been amazing so far. So these sessions, and I'm myself included, sharing some of the stuff that we've been doing, but from a very clinical perspective. It's all about how it works. And we brought videos, a whole load of people. You will meet a lot of my patients during the course. And you can see the changes. And I think that's the most exciting stuff. So you can see it, and that's compared to chronic pain, you don't see it, right? Which is obviously something we are trying to capture on video so you can actually see what's happening. So that's about it, I guess.
It's great. It's a great masterclass. We're already getting brilliant feedback about how much people are learning and how good it is and how easy it is to apply what they're learning within their clinics with their patients. So I've put the link in the chat. Please do go on, check it out, and it's available with the pub membership. So from myself and Bart, we hope you have enjoyed this webinar today. We absolutely love doing these. We love connecting with you. We love being able to answer your questions. If you want to see the recording of this, then it's on our YouTube channel. Jump on there. There's this month's session. There's a session from last month where Bart gave an introduction to FND, and there'll be another session next month. So join us again then, and we will look forward to doing that with you. Thanks again, everybody, and enjoy the rest of your day.
Cool. Thank you. Bye.
Take care.
Ciao.
Bye-bye.
Au revoir.
Yeah, nice.